Good morning, everybody. Thank you very much for the warm welcome, Matt, and thank you very much to INSU and the organising committee for inviting me here today to present this keynote. It's actually my first time in Athens. What an amazing city. So I was up at the Acropolis yesterday and got to climb up to the top to see the Parthenon, and it's extraordinary and reminds me of the importance of democracy and people and good democratic processes. So today I've been asked to talk about decriminalisation, legalisation and regulation. The brief, as some people may know from INSU, is fairly strict. Describe decriminalisation and legalisation regulation models and their pros and cons, summarise the evidence for impacts, provide 3 to 5 key takeaways, and do all of this in 20 minutes. I've clearly been set up to fail. I'm certainly not going to be able to do that. As I was saying to Tom earlier, this requires a course, not a 20-minute presentation. There are so many models, the terminology is not settled, there's varying levels of evidence, and of course there's controversy and politics. Where would we be in drug policy without it? So I'm going to start with 6 models. I'll start with talking about some models. So decriminalisation and legalisation models. It's almost impossible to describe all of the regulatory options. The models vary very widely in their detail. They also vary depending on the substance. So there's much more variation for cannabis than there is, for example, for opioids or for stimulants. And of course, many people, including people here, have developed great diagrams of the regulatory spectrum. Here's just 3. The regulatory continuum from Canada, which starts with the death penalty and finishes with commercial production. On the top right from John Corkins and Bo Kilmer and colleagues, their different supply options for the regulation of cannabis. And then down the bottom, the very famous U-shaped curve, originally from Marx in 1987, that describes the kind of regulatory spectrum. I'm going to talk about 6 different models. They're deliberately not placed on a continuum, and I'm going to go through each one of these and describe the features of them and then give a couple of examples. So, of course, there are the prohibition models, and note the plural. All of these have multiple models within these different categories. Prohibition is where the use of drugs and the supply of drugs and the possession of drugs, whether for personal use or for supply, remain criminal. And of course, there are many countries around the world that exercise prohibition models in their response to drugs. Another set of models concerns drug use and possession for personal use, and generally involves the removal of criminal penalties or softer criminal penalties for use. Supply remains illegal under these models. They're variously referred to as decriminalisation, depenalisation, or diversion. And these models have been around for a long time. In fact, in Australia, one of our states, South Australia, decriminalised cannabis back in 1987, and Brazil most recently this year decriminalised cannabis. Some countries have decriminalised all drugs. Czech Republic was one of the leaders in this in 1990, and more countries are now added to this list of approaches within this second cluster of models. The third cluster is the sort of cooperative or social club, and I've included home cultivation in here. These models, they don't just apply to use, sometimes they apply to supply. They can exist within the law, so supply and use can still remain criminal, or they can exist with variations of the law. And cannabis social clubs is probably the best example of these kind of models. They're community run, you have to be a member, they're not for profit, and Spain and a number of other countries have a long history of cannabis social clubs. Germany has recently legalised home cultivation of cannabis, which is another variant of this. Again, supply is illegal, but home cultivation is legal. And of course, the Drug User Liberation Front in Canada with their Safe Supply program, I actually think this is an example of this kind of model. It operates within a criminal environment, but it provides drugs to people who use drugs. Then another set of models are the more medical or prescription type models. So here personal use is legal, but supply is restricted to be available through prescription. All other versions of supply are illegal. And the Canadian Prescribed Safe Supply program, I think, is an example of this kind of model. There's a tension in this cluster of models about whether this is drug treatment or whether this is supply of a substance for recreational use. Some people would classify heroin-assisted treatment as a version of legalisation or available supply. Other people would classify it as a drug treatment program, and there's an interesting tension of the boundaries around those prescription type models. The next one is government monopoly models. These are really familiar to people who have studied alcohol policy. This is where the government owns the supply chain of the product. So in Scandinavian countries, alcohol is supplied by government. They produce it, they sell it in government-run stores, and they can therefore limit the advertising, the trading hours, the price, the product, all sorts of different restrictions. And Quebec in relation to cannabis is probably one example. Cannabis is not exclusively available in government stores in Canada, but this kind of government monopoly model is gaining in popularity in relation to cannabis. Governments producing opium and heroin and supplying it in stores would be the model for opioids or stimulants. And then the last cluster of models are the commercial models. These vary enormously. Personal use is legal, supply is legal through for-profit arrangements. Regulations vary enormously by country and by region. And we're very familiar with this for those countries where alcohol is legal and nicotine is legal. And of course, these are the models that are being pursued in Canada and some states in the US in relation to cannabis. So some important things about these models. This is a bird's eye view, a big picture of these 6 options. Within each, there are hundreds of variants. The key differences are about how use is treated versus how supply is treated. And that's really what distinguishes the different types of models. In terms of drug type, there's much more evidence about cannabis. So the systematic review by Sharman colleagues on regulatory options for illicit drugs, they located 114 articles, of which 109 were cannabis, and there were only 5 studies for drugs other than cannabis, and of course Portugal featured in that cluster. There were 96 studies on the legalisation of cannabis and only 19 studies on decriminalisation of cannabis or other drugs. And the other important difference that will become apparent a bit later is whether drug law reform is conducted in the law, whether the law actually changes, that's known as de jure, or whether it changes just in police procedures. And that in that sense, there's no change to the law, but the police operate differently. And of course, many countries have got models. These lists are incredibly hard to do, as anyone who's tried to do this knows. So on this side are the de jure decriminalisation. These are countries where the law has been changed and criminal penalties have been reduced or removed, and I've summarised the consequences. And on the right-hand side are countries or places where there's de facto decriminalisation that includes police diversion or depenalisation. And there's probably people here who say my country's in the wrong box or my country should be up there. Yes, indeed, and apologies for any errors. They are all my own, despite an excellent set of sources, including Talking Drugs, the UDA, and various other reports. So there are many claims about the positive impacts of drug law reform. These claims are used by researchers, by advocates, and by government, with different reasons for why they would assert a certain claim about what would happen under drug law reform. But there are a set of common claims: that drug law reform will reduce stigma, will improve access to healthcare, improve health, be cost-saving, and so on. And these claims are very common. Most people here will be very familiar with this set of different claims. Some of them apply only to decriminalisation, others only to legalisation. I wanted to ask the question, will it? So I'm going to walk you through an analysis for the decriminalisation, that's the removal of criminal penalties for use and possession for personal use. I'm not going to walk through an example of legalisation. And at this point, with some trepidation, I'm putting my hard hat on and I'm a researcher at this moment in time. So there are 4 outcomes that I've chosen to explore. The reduction in stigma, the improvement in health, the decrease in fatal overdoses, and the decrease in arrests and incarcerations. And I want us to ask ourselves, what's the potential mechanism by which changing the law and removing criminal penalties from law would produce these outcomes? So let's take stigma and discrimination. So what's the mechanism by which stigma and discrimination would be reduced if we change the law? So it's no longer criminal, so people will be able to talk about their drug use. The community would be more accepting of people who use drugs. I think they're the kinds of mechanisms. We don't have any evidence, although I know people here are collecting evidence, which is great. There is a very important report by Input, which I call the red herring report, which has some qualitative evidence about reductions in stigma experienced by people under decrim, but it's also got evidence of increasing forms of stigma under decrim, and that's important to recognise. So I'm not sure about reductions in stigma and discrimination. How will removing the criminal law for drug use or possession for personal use improve health? People will be more likely to seek help because there's reduced stigma. Well, we'd need the stigma mechanism to jump in first. The second way it might improve health is by mandatory referral to treatment instead of a criminal penalty. It might decrease risky injecting practices because people are no longer fearful of arrest. And it might expand harm reduction services because you don't need those legal loopholes to offer good harm reduction. But you'd need resources, you'd need harm reduction to be funded. Or it could improve health through reducing incarceration, which I'm going to talk about at the end. So the evidence for this. So yes, there was improvements in health in Portugal, but Portugal has commissions of dissuasion. They have mandatory treatment. So the effect of getting improved health from decrim relies on a mandatory referral into treatment, not a model, I would say, that many people, particularly people here, would support. And this is also the experience in Germany. You see improved health from the German research. They have a mandatory referral program. In relation to HIV and hepatitis C, there's research that shows that improvements in health can occur under decrim, but all of those effects in those studies rely on decreasing incarceration rates. So it's not a direct effect. You have to decrease your incarceration rate in order to get the improvements in relation to hepatitis C and HIV. So let's go to decrease fatal overdoses. What's the mechanism by which changing the law would decrease fatal overdoses? It would decrease risky injecting practices. People aren't fearful of arrest. Maybe bystanders were more likely to intervene. It might increase access to harm reduction services. That relies on the mechanism under the improve health column. Or it could be through improvements in health, but that would rely on the drug treatment mechanism, potentially making that mandatory. And indeed, as shown by some excellent work from Oregon, there has been no change in the fatal overdose rate, largely because of the underlying overdose rate associated with the decriminalisation reforms in Canada. Portugal did see a decline in fatal overdoses back in 2000, 2001, when it decriminalised the personal use of drugs. But their overdose rates are now climbing, although they remain lower than the European Union average. And then the last one, surely we can get a decrease in arrests. Surely decriminalisation would produce a decrease in arrests. Yes, thank God. Oregon, Washington, Portugal, there's lots of evidence that if you decriminalise the personal use of drugs, you do get a decrease in arrests if you implement it. The work from Mexico demonstrates that there was no change in the number of arrests because the police didn't implement the changes in the law. So will it reduce incarceration rates? Well, the logic is if you're not arrested for drug use, you won't go to prison. But incarceration is multi-determined. For this effect to occur, it relies on people being incarcerated only for drug use offences and not for other offences. And for the epidemiologists, you need to know the etiological fraction or the attributable fraction of drug use and incarceration. And in fact, there's not strong evidence. And when you drill into some of the incarceration rate data, you can see most people are incarcerated for multiple offences, including supply-related offences. And so you might not get that effect. So what can you conclude? So first up, the outcomes absolutely depend on the model that you're implementing and actually implementing it. So implementation is rife with failures around the globe for decriminalisation. I think we haven't talked enough about these mechanisms. I think our enthusiasm for the claims that we have been making, and I include myself in this, has not been married with strong evidence. And this is partly because the evidence is complicated. What I've been describing in very simple terms is actually a complex set of causal chains with time lags, with multiple effects, which will vary entirely by context. So if you have a very low underlying HIV prevalence rate, as we do in Australia, the decriminalisation of drugs is not going to reduce HIV in Australia. In another country with a very high prevalence of HIV, absolutely. So you've got the same model and you've got two different effects. What's your drug treatment availability like at the moment? If you've got a country with terrible drug treatment availability and no mandatory referral and people can't get into treatment when they want it, you're not going to get improved health outcomes through that mechanism when you decriminalise personal use of drugs. And importantly, what's your incarceration rate like? How many people are sent to prison for simple drug use offences as opposed to other offences? And what's the attributable fraction for each incarceration event that we might ascribe to drug use, which can then respond with the mechanism of improved health? So at this point, I'm really cautious about claims about the positive impacts of drug law reform, and that might be really disappointing to many people here in the audience. And now I'm going to take my hard hat off and pop it over here and present an alternative point of view. And that is that evidence doesn't matter because this is a social justice issue. And I found this quote, "The central cause for drug law reform is not its relevance to health or to the present public health catastrophe. It is a matter of correcting a social injustice." Now, this is where the language completely changes, I think. Let's just begin to design the best decrim or legalisation model. However, forget about the evidence of which one works. Which model do we choose and how do we make a decision? Now, I'm not going to spend a lot of time on this. This is work we've been doing in Australia about sort of flow charts of decision-making around decrim. The slides will be available. Who's eligible for this kind of model? How do you distinguish use from supply? What happens to people? Do you scrap the mandatory treatment? Do you give them a fine? Does nothing happen? And what do you do about non-compliance? So how do you decide on the best model, in this case, decriminalisation? Well, luckily, some very smart people, including people here in the audience, have worked it out for us, and that would be Input and IDPC, who present a gold standard model of decriminalisation. I won't go through the features. They're available on the IDPC website and in the Input Red Herring report. So we've got a gold standard model, right? Could I find a single country or province or state that has this model? No. Please correct me if I'm wrong. We absolutely don't have a gold standard for legalisation. We've got alcohol, we've got nicotine, and we've got cannabis. We've got evidence up the wahoo in relation to cannabis legalisation, but people can't agree on what the evidence is saying, probably because context matters. We have the World Health Organization best buys for alcohol, very familiar to someone like me who also studies alcohol policy, but this isn't a model for legalisation. This is more, how do you respond once the horse is already bolted in fully commercial models for alcohol? And I really don't think there's going to be a gold standard legalisation model. Maybe there will be with time, but I couldn't envisage it preparing this presentation. So I've only just touched the service, right? Not talked about a whole lot of really important things. The International Drug Convention's got a paper on that somewhere. The politics, the public understanding of these issues, public opinion. Who gets to decide the model, right? What's the process of policy development, and where do people who use drugs fit in? Haven't talked about racial disparities in policing. I haven't talked at all about the evidence for cannabis legalisation. More than 80 studies published from 1 January 2024 on cannabis legalisation in IJDP, the premier journal for drug policy studies. I haven't talked about human rights. And I haven't talked about this last dot point, which I did want to say something about, and that's the difference between studies of the effects of criminalisation, like Cora DeBeck and colleagues' fantastic systematic review, and studies of the effects of decriminalisation. You can't assume that a study that shows criminalisation produces harms means that if you remove that criminalisation, those harms will be reduced, unless you sort out the mechanisms. And I'm now going to conclude with my instructions for my 4 key takeaways. The first is that the model does matter, and there are really dreadful examples. Some people might have seen Russia's on the list for de jure decriminalisation of all drugs. Implementation matters even more than the model. I'm almost tempted to say it doesn't matter what you do, just if you implement it, get the police to behave differently, might be one takeaway. The second is to really think about the fact that outcomes, and I've used the example of decrim, not legalisation, don't occur in a vacuum. So the outcomes that you achieve in your country or your state or your province will be driven by the context within which it is occurring. Every place will be different. It'll depend on your underlying prevalence of HIV. It'll depend on your drug treatment system. It'll depend on your incarceration rates and your etiological fractions. We need local evidence, local experiences, and we need local models, not people like me standing up here and saying what the best model is. My third takeaway, which is woven throughout this, is the issue of the risk of overselling. Matt's getting nervous now. People in Canada know about the terrible public backlash that's happened in British Columbia through Bill 34, for example. And it makes me wonder whether we set ourselves up for that by arguing about the positive effects of decriminalisation and arguing for the positive health effects for the reduction in fatal overdoses. And I've done it. I've presented to politicians and I've said, you know, this will improve health, this will do this will do that. So we've all done it. But maybe we need to be more careful and be clear about what we expect from decriminalisation and what the mechanism is. Now, we don't need to talk about this with the decision makers, but at least internally to have those kind of conversations, I think would strengthen us, because ultimately this is about getting drug law reform up. We have big gaps in the evidence, and it is not yet a self-evident, sort of obvious no-brainer idea. That's where we need to be, where drug law reform becomes completely self-evident and obvious, not just to the experts, not just to the people who use drugs, not just to the politicians, but to every person in every community. Thank you very much.